Welcome. Thank you for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General.
My name is Maria. I am a public health intern at the Blum Center.
Today's program is part of our genetics series, a special collaboration between the Blum Center and the Center for Genomic Medicine at Mass General. Before I get started, I just want to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, it'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Please note that you are in listen-only mode. Everyone has muted so you can hear our guest speaker today. If you have any questions for our guest speaker, you may use the chat feature, which is located at the bottom of your screen. We'll have time for in the end. Only Blum Center staff and our guest speaker will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we'd like to ask you to help us complete. Your feedback is important to us as we plan future programs. Okay, so next I'm going to hand it over to Maria, who will introduce you all to today's guest speaker.
Thank you, Amy. It's my pleasure to introduce the speaker for today's talk, Dr. David Sweetser. Dr. Sweetser is the Chief of Medical Genetics and Metabolism at MGH and an Associate Professor of Pediatrics at Harvard Medical School. He has a special interest in rare and undiagnosed diseases and is the Site Director of the Undiagnosed Diseases Network at MGH, the Director of the Nord Center of Excellence for Rare Disorders at MGH, as well as an attending physician in pediatric hematology and oncology. He oversees the Medical Genetics Division at MGH, which has 12 geneticists, 4 genetic counselors, and 2 metabolic nutritionists, and specializes in the evaluation and care of pediatric and adult patients who may have health problems with a hereditary, genetic, or metabolic basis. And I'll go ahead and turn things over to Dr. Sweetser.
Great. Thanks, Amy and Maria. So I'd like to thank the Blum Center for inviting me to talk about this topic. The title of today's talk is Ehlers Danlos Syndrome, What You Need to Know. And there's probably a few other disorders in medicine that I think are less understood by both medical personnel as well as many patients. And the syndrome and its manifestations and similar related syndromes can be very complex and challenging to take care of. So I'm hoping that this session today will provide some very useful information and a good broad overview, not only for both individuals who may have some concerns about this topic, but also for providers who could use an overview about this topic. So for today's talk, we got a couple of goals. First, just briefly going to give you an overview about hereditary disorders of connective tissue, which includes Ehlers-Danlos syndrome. The talk today is really going to focus, though, on two disorders, hypermobile Ehlers-Danlos syndrome and hypermobility spectrum disorder, and we'll have a chance to explain those in a lot more detail. I'm going to talk about the symptom management for hypermobile Ehlers-Danlos and hypermobility spectrum disorders, and also some guidance about those of you who may be seeking an evaluation or providers who need some guidance about when to refer patients to us and when to defer referrals to our medical genetics department in lieu of other specialty providers. So just as an overview, Ehlers-Danlos is one of many disorders that fall under this category of hereditary disorders of connective tissue. You may recognize some of the other common disorders here. Marfan syndrome, you may have heard that name. Loeys-Dietz syndrome, maybe not. That's a little less common. the Ehlers-Danlos syndromes, there's actually 14 different subtypes, as we'll review on the next slide. Hypermobility spectrum disorder, osteogenesis imperfecta, a problem with the bone mineralization. And there's not quite a number of other names that are on this list here. But today's talk, again, is going to focus on Ehlers-Danlos syndrome and just an equal focus on this topic of hypermobility spectrum disorder. As I mentioned, there are actually 14 different subtypes of Ehlers-Danlos syndrome. And these different subtypes, by and large, have some very characteristic features for each one of these subtypes. And there's also some overlapping features. And I'm not going to go through the whole list here, but the most common ones on this, amongst this whole list, is hypermobile Ehlers-Danlos. By far, that's the most common subtype of Ehlers-Danlos syndrome. The others that we also see not uncommonly is classical Ehlers-Danlos syndrome and vascular Ehlers-Danlos syndrome. And the others are pretty rare. And as you look on this list about the genetic basis, you can see that for all of these different subtypes, there are causative genes. So there is genetic diagnosis that you can do, with the exception of hypermobile Ehlers-Danlos syndrome. So this, we do know, is a genetic disorder in the sense that it can be inherited, and many times in an autosomal dominant fashion. That means if you are affected, half of your offspring will also have similar symptoms, but there is no genetic test for it. Even in this day and age where we have the most advanced genetic testing, sequencing the entire genome and looking how it's modified, to this day, no one has actually been able to find the gene or the cause of hypermobile Ehlers-Danlos syndrome. So that's one of the important points about today's talk, is that there is not a genetic diagnosis for hypermobile Ehlers-Danlos, and we rely really on using our clinical criteria for making that diagnosis. And as I mentioned, there are a lot of very specific features for some of these different subtypes of Ehlers-Danlos syndrome, but there's also overlapping characteristics. And by and large, all the ones on that list to some degree have some evidence of joint hypermobility. Easy bruising is also included in there. But vascular EDS, for instance, is a very distinct category. There's often both physical features that you can recognize in the face, but also, more importantly, some major life-threatening manifestations that you may see. Spontaneous collapse of the lung, internal organ ruptures. This includes, as in the bottom there, arterial dissections and ruptures. The other internal organs could be rupture of the intestine or the colon, or a rupture of the uterus during childbirth. Those are obviously very life-threatening and potential causes of mortality with that disorder. Classical EDS has extreme tissue fragility as one of the main characteristics of that. And this can be severe enough that can cause multiple problems with surgery, with sutures that don't hold very well, sutures that will come undone, as well as some of the other problems that are mentioned here with atrophic scarring of the skin for mild injuries, different hernias. This concept of hypermobility spectrum is actually a bit more encompassing. It is reserved for disorders that have some hypermobility, and we'll talk about that a little bit more. It excludes other clearly diagnostic categories of connective tissue disorders, including Ehlers-Danlos syndrome, chromosomal conditions. So one example, for instance, is patients who have Down syndrome. They tend to have very lax joints and very soft, loose skin, and that's not considered a hypermobility in this category of hypermobility spectrum disorders. But they do have joint hypermobility and instability, easily injured in terms of their skeletal system and pain and a number of other associated problems. When we're talking about hypermobility, it's not just a yes or no, but as you are all kind of aware of, that there is a spectrum in the population of the degrees of hypermobility that somebody may manifest. There can be people who consider themselves extremely stiff and even less mobile than they should be, quote unquote normal. There are others who have relatively looser joints that aren't causing any problems, but may actually be some benefit in some ways in terms of potentially with gymnastics, for instance, or ballet. And then you start to get into the greater mobility than typical that stretches into hypermobility spectrum disorder, as well as hypermobile EDS. And one of the ways that is commonly used to at least document hypermobility, for better or worse, is what's called this Beighton score. And so if you come in and are being evaluated for hypermobility, this is one of the evaluations that we'll do. And you can see some of the maneuvers that are used for part of the scoring system. Try to bend the fifth finger back greater than 90 degrees to see if the thumb can bend all the way back to touch the forearm, whether the elbow bends backward greater than 10 degrees, whether the knees bend backward greater than 10 degrees, and also whether or not with your legs extended, you can put your palms flat on the ground. And so if you add all of these up, for the first four, you can get 2 points if you can demonstrate that degree of mobility on each side of the body, and then you get 1 point for putting your palms flat on the ground. And so you can get a total of 9 points if you get all of the points. And what's considered to be hypermobile in adults is a score of 5 or greater. Now, children tend to be overall more flexible, and so to score positive on a Beighton scale for a child, you need 6 points, whereas for adults over 50, everybody gets less mobile as you get older. Having 4 points would give you that score of hypermobility. And this is just some pictures about how we measure all of these different things. You know, how far past the midline you can bend your elbows. This is showing your thumb bending back and touching your forearm, as well as the knee hyperextending there. Now, there can be problems that are associated with this hypermobility, and often these joints have more physical stress that's associated with them, and that can lead to micro and macro trauma, degenerative joint disease and bone disease, early arthritis, as well as just disturbed proprioception and muscle weakness that can be associated with it. And then, as we're going to spend a fair amount of time, there are also individuals who have this joint hypermobility also have manifestations throughout the body that affect multiple other systems. This is just a picture of the knee, just to show you the knee and all the tendons and all the articular cartilage that's there. And wanted to highlight the fact that a major component of all of these different connective tissue, the tendons, the cartilage, as well as the bone, is collagen. And collagen is at the center of what we're going to be talking about today. Collagen is all throughout your body. So when you start talking about collagen, weaknesses of collagen, you can have multiple manifestations. You can think about it in the spine, where the discs of the spine are also have a lot of cartilage, and if there's a weakness, you can get degenerative joint disease. You can have outpouchings of the dural that can lead to fluid that's pushing out against the nerves that are coming out of the spinal cord, and some of these outpouchings they call Tarloff cysts. You can have weaknesses of the pelvic floor that can lead to a number of problems that we'll talk about. You can potentially have what's called a Chiari malformation, where the brainstem is pushing out in past this opening of the foramen magnum that might be causing some neurological problems. The blood vessels, yeah, you need collagen to maintain the proper tone of all of your blood vessels. So all of this connective tissue here that's giving a nice healthy blood vessel is dependent on collagen. Your intestine is also wrapped in layers of connective tissue, of which collagen is an extremely important part. And even when you take a look at the nerve fibers, there's multiple parts of the nerves and these groupings of nerves, these some of these components that they call the epineurium, the perineurium, as well as the surrounding sheaths, is also highly dependent on collagen for its integrity. So if you start talking about a weakness of collagen, you can rapidly see that there's a lot of systemic manifestations that you might encounter. And if we back up a second and talk about just hypermobile Ehlers-Danlos syndrome. So there's a few just kind of general features that we commonly associate with this disorder. Generalized hypermobility, which can lead to problems such as ankle sprains, subluxations of the joints, where the joints feel like they're loose, actual frank dislocations where they come out of the sockets, chronic musculoskeletal pain, early arthritis, because the collagen, the cartilage that's lining the joints is weak and degenerates quickly, especially with high impact activities. Can have orthostatic intolerance, lightheadedness, or syncope when you stand up. GI disorders are really common, as well as fatigue. And this, as I mentioned before, this is the most common subtype of EDS that we have, and it's the most common of all of the hereditary connective tissue disorders. Just to reiterate this, we do not know what the genetic cause is, but it is clearly a genetic component because it does tend to run in families. And back in 2017, the International Consortium of Ehlers-Danlos had put together criteria, not only just to define, at the time were 13 different subcategories of hypermobile EDS, of EDS, including hypermobile EDS. And they came up with some very strict clinical diagnostic criteria for hypermobile EDS. And with the goal of promoting consistency in making this diagnosis, prior to this point, it used to be that anybody that walked in the door that was a little extra flexible would just get stamped with hypermobile EDS. And one of the other goals was just related to the frustration that all researchers have had is trying to figure out what causes hypermobile EDS. And the thought was that if you could really define a subgroup of those that have the most significant symptoms, and started to focus your genetic testing and analyses on that, we would be able to come up with a diagnosis. The latter point hasn't happened yet, and we're talking now over 7 years since these criteria were established. It does, however, leave us with having these criteria if we want to kind of abide by the medical community in making this diagnosis. And so wanted to just discuss about kind of the implications of that. And as I mentioned, we do have diagnostic criteria about how we can officially diagnose somebody with hypermobile Ehlers-Danlos syndrome. And so this is what these criteria look like. A central portion of this is joint hypermobility. So you're not going to get a hypermobile EDS diagnosis unless you have hypermobility. And they use this Beighton score. Now, this is kind of another point of contention amongst the medical, in the medical community, because you can certainly have hypermobility of other joints. And if you recall what they were looking at, they were mostly looking at the hands and the elbows and the knees, and the spine flexibility. But there are many people who have hypermobility and dislocations and subluxations of their shoulders, for instance, or their hips, for instance. And that isn't met on that criteria. So we may actually have somebody who has a lot of those other features, but when you come down to really scoring them on the Beighton scale, what they're asking, is the elbows may only bend back 8 degrees and not 10 degrees. And, you get into sort of just parsing the diagnosis, and sometimes this is kind of an issue of potential contention, but that's one of the criteria. The second criteria is that you need to have at least 2 of these different features. One of the most common ones that we can click off is daily pain in the limbs for more than 6 months and chronic widespread pain or recurrent dislocations. So many of the people that would be contemplating a diagnosis of this often have that as a feature. The other is a family history of EDS. And this is a little bit subjective, because by right, what they're saying is that you've had a family member that met all of these diagnostic criteria. And when you're talking about somebody's mother or grandparents, you can be almost certain that they probably weren't subjected to a rigorous evaluation where they met all of these criteria. Sometimes that's a little bit soft. If you do see somebody who sounds like they could have had EDS, it's kind of a question whether you click that box or not. And then there are some systemic features that are common with EDS. And I've listed these all here, and you go through this list and you both evaluate the patient and ask the patient. The skin is often soft and velvety, and this is a real characteristic, almost somebody who's got soft skin, like they've recently put lotion on it. You can see some degree of hyperextensibility, whether they have stretch marks that are unexplained, so not related to weight gain or rapid growth during adolescence. There's this other feature of pisogenic papules, and just to kind of give you an idea about what these are, this is referring to some outpouchings of kind of fat on the heels. So if you're asked to take off your heels and stand, and somebody's kind of feeling your heel pressing out, they're looking for these little bumps, protrusions of fat that you might see in the heels. Atrophic scarring that has to be in more than 2 sites. And so here we're talking about cuts or stitches that didn't heal, where the ends didn't oppose nicely, but they've kind of stretched apart, and you get this cigarette paper thin nature to the scars. Hernias at multiple sites, these organ prolapse, and we talked about these, whether it's rectal prolapse or uterine prolapse, or some of the ones that you might see. Dental crowding, often these individuals will have needed braces, some teeth that are extracted. High arched palate is really common with this. Arachnodactyly, which is basically long fingers and arm span to height ratio that's greater than 1.05. Mitral valve prolapse or aortic dilatation. There's people who might not have had an echocardiogram. This is not, as I mentioned, with hereditary connective tissue, there can be a lot of overlap. And by and large, the aortic dilatation that you may or may not see with hypermobile EDS is not in the same category as vascular EDS. It's usually mild, and it doesn't progress as it can with vascular EDS. And then the third is just the absence of something else, another connective tissue disorder or another diagnosis that could explain the features that they've got. And this is just a one-page sheet that you can find if you go to the Ehlers Danlos Society page, and this is what a physician might use to kind of check all the boxes to see whether or not you do meet this actual diagnosis. Now, there are many people that come in and you count up all these points and you say, well, you come up 1 point shy or 2 points shy, and it's not necessarily very satisfying. And it does point to this issue, actually some controversy in the medical community about whether or not hypermobile Ehlers-Danlos is a distinct category or whether it really is just part of a spectrum, whether or not there's a single genetic diagnosis that hasn't borne out so far, or so there is sort of this somewhat artificial cutoff that people have made for this to get the diagnosis of hypermobile EDS, but it really isn't, in many ways, an artificial cutoff. For those that don't meet that diagnosis of hypermobile EDS, but have other features, there's this category of hypermobility spectrum disorder. And the diagnosis is less strict. There can be some distinction about whether it's generalized hypermobility, whether it's affecting just the hands and the feet or one specific joint, or whether it's more historical in nature. And so here's a list of some of the problems you can see with hypermobility spectrum disorders. They also are seen with hypermobile EDS, but the joint subluxations, dislocations, joint pains, loss of joint function, joint damage, early arthritis, osteoarthritis, damage to the ligaments, chronic recurrent pain, poor proprioception. So these are all musculoskeletal issues. But those are not always the most debilitating symptoms that you can see with these disorders. Those certainly can be very significant, but there's a lot of other manifestations that we can see with these disorders. Orthostatic hypotension, feeling light when you stand up or passing out, autonomic dysfunction we'll get into, fatigue, gross fatigue, exhaustion. People describe themselves as their body's like a battery. It's hard to get fully charged. You can exert yourself for certain activities, but if you over discharge the battery, it takes a long time, a day or more, before you can recover, and you have to pay, basically budget your time and your energy, or do activities knowing that you're going to have some consequences in the following days. GI problems, pain, headaches. We'll go through all of these other different things, including mast cell activation at the bottom here. And so regardless, that's just another point to hammer home, is it doesn't, in many ways, it doesn't matter if you get this diagnosis of hypermobile EDS or you get a diagnosis of hypermobility spectrum disorder. All of the features that you can see with hypermobile EDS, you can also see with hypermobility spectrum disorder. And again, I'll say this over and over, we don't have a genetic test for this. It's a clinical diagnosis. And these are features that are really real. They're significant, and they do need to be treated, but they're not treatments that a geneticist would give. It's very common that people come in and they just don't understand all the consequences you can see with a connective tissue disorder. And a common lament is that I've got so many things wrong with me that nobody can figure out what's going on. You see different subspecialists here, and nobody is kind of putting the whole picture together that there's a hypermobility spectrum disorder at the heart of all of this that's explaining all of these issues. Not to go over all of these musculoskeletal issues, we talked about a lot of these. The knee, you can get a patellofemoral pain syndrome just because the patella isn't tracking right when you bend your knees. The feet tend to be flat, need some arch support. A lot of spine issues, temporomandibular joint dysfunction, pelvic floor dysfunction that can lead to many issues, including stress incontinence. This is a very common symptoms that we'll see with patients who have these hypermobility spectrum disorders, is orthostasis, also called postural orthostatic tachycardia syndrome, and fatigue. And in some sense, there is a, a, a low cardiac output is the problem here. And if you think about the fact that, as we described, collagen being really important with having blood vessel tone, it's when people stand up, there's a reflex. The nerves fire, contract muscles around your blood vessels and redistribute your blood flow so it goes back up to the heart. Otherwise, everybody would feel dizzy every time they stand out or pass out. And so this is what we call a preload failure. So the load of the blood that's getting back to the heart is decreased. And so if you don't have enough blood flow that's getting back to your heart, you're not pumping oxygen to the rest of your body, to your brain, to your muscles, to your gut, to work optimally. So this is a huge part of the symptom complexity that you see. You can also get tachycardia. So if you stand up, your blood pressure drops, your heart rate does compensate by beating fast, but you can also have inappropriate tachycardia, where even if the blood pressure isn't necessarily dropping, but in response to activities or changes in position, you can get a severe sinus tachycardia with your heart pounding and palpitations. And that's something that you can also see with a hyperadrenergic form of POTS. And I mentioned this here. So if you're not getting blood flow and you're not getting oxygen to your muscles and your brain, you're going to have symptoms. And there's another phenomena that's not realized even by many of the physicians, and even when autonomic function testing is done, it's not always appreciated in the readout of those tests. This other phenomena, and that's that very commonly there's shunting away from the capillary beds. So if you're trying to get energy to your muscles, you want to get the oxygen to your muscles, and your blood vessels at the very end, they break down to the capillaries, and the capillaries is where the oxygen exchange happens. And with these disorders, there's commonly shunting that's away from that. So you're not getting oxygen. And that's something that can't be measured sometimes on these autonomic function testing, is about how well the muscles are extracting oxygen. And the common description on these reports, which is really very deceptive, is they say indicative of mitochondrial dysfunction, because the mitochondria are what are using the oxygen. But this is not a mitochondrial disease. So that's a huge misconception that comes in the field here, is that there's something wrong with the mitochondria. And there's nothing wrong with the mitochondria per se. They might not be getting the oxygen that they need. And the other thing that is real is deconditioning. So because of the fatigue, you can't exercise at a high capacity. And as you do exercise, especially with high aerobic, anaerobic activity, it is a stimulus for multiplying your mitochondria. So your mitochondria are very dynamic, and they can expand. If you take an elite athlete, an Olympic athlete, and you were to look at the muscle, there's a lot of adaptations they have. The blood vessels are bigger. They can rapidly pump more blood through their muscles. They've got many times more mitochondria packed in all of the muscles that we do. But if you were to take one of those athletes and stick them on a couch and say, you can't do anything for a week, they'll rapidly decondition themselves. The mitochondria, they start to lose the mitochondria and get deconditioned. And that happens also. That's a big problem here, is that in a sense, there's mitochondrial dysfunction just because you have fewer mitochondria. But this is not a mitochondrial disease. There is another aspect that you can see with these disorders that's called autonomic dysfunction. So your autonomic nervous system is basically the nerves of your peripheral nervous system that control the things you don't have to think about, like regulating your blood pressure, regulating your sweating, regulating your body temperature, and many other functions. And so people, and this is probably related to, as I showed you that picture about the nerve, and show another picture of it again in the next slide. Some people believe that the fact that there's a collagen weakness that can affect the integrity of the small nerve fibers that are involved in the autonomic nervous system is one potential explanation. But this can lead to both the orthostasis. So if you're trying to regulate your blood pressure when you stand up, like I said, you're at a disadvantage if you've got, so to say, floppy blood vessels and poor capacitance, so the blood is pooling, but the nerves that are supposed to be firing to the muscles to contract the muscles around your blood vessels aren't working either. So you can kind of get a double whammy, so to speak, of effects on the lightheadedness that you might see. I mentioned these other things about palpitations, sinus tachycardia, the decreased sweating. So this is another thing that we will elicit in the history, is either they don't sweat, they have very poor heat intolerance, or they might have abnormal sweating, like extremely sweaty palms and feet, or sweating in places you wouldn't necessarily think about with exertion. Urinary issues, so just controlling the bladder function for weakness, loss of control, urinary retention. Sexual difficulties are really underappreciated with these disorders. GI dysfunction, and we'll talk a little bit more in detail about that. Exercise intolerance, as well as just neuropathic pain. So these can be pains just without any reason, where your hands and your feet are painful, or they're burning, or you get pins and needles and sensations in your hands, paresthesias. And so just to reiterate some of these, the GI dysfunction that you can get, excuse me, sleep problems, brain fog, where your brain just isn't getting, circulatory issues, discolorations of the legs and the extremities. Excuse me. And then the GI problems are also not to be underestimated, because these can be extremely severe in some people. Sometimes it's just mild, but other times they can be really totally debilitating. You can not only have nausea and vomiting after meals and reflux. Your food may get stuck in your esophagus. Problems with eating and maintaining your weight. Dysmotility of the intestine. So again, you've got an intestine that isn't moving food through properly. That same analogy, if you'll excuse the phrase, like a floppy intestine, where it's just stretchy. It's not a good tube. There's not efficient peristaltic contractions that are there that can lead to significant dysmotility, both in terms of constipation, or you may sometimes have, less commonly, diarrhea or irritable bowel syndrome. But these symptoms of bloating after eating and severe abdominal pain and cramping are also very common issues to potentially deal with. The pain can come from multiple sources, and we've kind of alluded to these. The joint pain, the GI pain, headaches, migraines are really common with this disorder. Neuropathic pain, the paresthesias, pins and needles sensation, and this small fiber polyneuropathy. So this can be a diagnosis all in amongst itself that's not related to hypermobility. But people who do have these disorders with hypermobility, not uncommonly, also will demonstrate a small fiber polyneuropathy. And that's where these small nerve fibers that are involved in the autonomic nervous system and the sweating and the like are damaged and not functioning properly. The cognitive symptoms, again, we talked about some of these, this concept of brain fog. Often people think of it as a pejorative term when they hear about a patient with brain fog, but because it's not something you can easily measure, but it's a real symptom, as well as, and it's due to impaired brain blood flow. Along with that, you can get anxiety and significant effects on emotions. Depression is really common with these symptoms. just in part because of the overwhelming symptoms that they're having and frustrations that people deal with. And very commonly, there's a downward spiral of people who just can't be active. They're depressed because they can't be active. Medications that they're getting can have side effects. They may get obesity. They're not able to work, not able to go to school. The other thing I had mentioned is mast cell activation disorder. So again, this is a disorder that can be all amongst itself, independent of hypermobility, but many of the symptoms of mast cell activation that you might see, skin flushing, itching, chemical sensitivities, as well as flushing after a hot shower, the headaches and sweating are also very common items that we see with the mast cell activation. And this is really a spectrum. All of these issues that I mentioned, some people have all of them, but very few. Most people, there's some selection of these different features that they have. And whether or not you're EDS, get a hypermobile EDS diagnosis, or you're the spectrum of hypermobility spectrum disorder, these are all the same issues that people have to deal with. And so this is really the crux of it. If you go to a geneticist, the geneticist isn't really going to do anything except maybe help steer your physician into thinking about these disorders and getting you in to see the appropriate specialties, doctors that can help you deal with some of the problems. Again, it's very complicated and it's not easy to solve all these problems. Physical therapy is a big deal. You can sometimes increase the strength and the stability of the joints. You have to go to a physical therapist who knows the types of exercises to do, that's used to dealing with hypermobility and some degree of activity every day, whether it's just walking on a treadmill, is really critical and a huge part in just improving many aspects about both your mental resiliency, as well as just improving even the cardiovascular conditioning that you've got. Pain management. There are some conditions that can contribute to chronic pain that should be assessed, hypothyroidism, other ones that I've mentioned here when we see somebody. But oftentimes you might need some help in a pain clinic. This is a chronic issue, so it's not something that you can solve by doing opioid therapy, for instance. Developing tolerance is sort of a lifelong issue that you have to find ways of coping and dealing with. This orthostatic hypotension, often it's the cardiologist, sometimes a neurologist that might help you with these symptoms. There are some medications, but really the heart of all of this is hydration with electrolytes. And just want to emphasize that. But this is a key problem, and oftentimes this is a huge contributor to many of the other system manifestations that we have. But you want to increase, so to speak, that word preload that I use. You want to increase the volume of the blood that's going to your heart, and you have to take fluids. But not just fluids. Lots of water is actually detrimental to your system because you can flush out the concentration gradient that you need in your kidneys to actually hold on to fluid. And salt is really the key. At least these are some guidelines for an adult. Some people even suggest even higher amounts of salt, but 2 liters a day, salt intake of 2 to 3 grams, generously salting all of your foods, salty foods, as long as you don't have problems with your blood pressure. And you need to take electrolytes. There's many, and you need to look at the label, because what you're looking at is a sodium concentration. There's many quote unquote electrolyte solutions out there and smart waters, and they just have tiny amounts of electrolytes there, enough to put it on the label. But you need something that's substantial, something that might be used by athletes, sweating athletes, and these are some of the ones that I've mentioned. Gatorade, the endurance formula, has a higher concentration of sodium than the standard one. Noon tablets, drip drop packets, LMM electrolytes, and there was others that you might find. But again, you want to be looking at the sodium content. And out of all of these, probably the lowest is Gatorade here. That's 300 milligrams in a serving. But that can improve the blood flow. It can improve that this brain fog can increase your energy. It may, in some instances, improve your GI motility. The POTS, is orthostatic hypotension, is probably the symptom that benefits the most from it. And there are other things. I'm not going to go through this list, but I want to, for those who do have dysautonomia, there are management guidelines that you can do, and these are kind of discussed here. And I want to keep pointing to the Ehlers Danlos Society. There's a lot of information that's on these web pages. If you just search for Ehlers Danlos Society, you can see those, including this list. Neurological issues. There's, as I mentioned, you can get this peripheral neuropathy, small fiber polyneuropathy, autonomic dysfunction, and this is in the realm of neurology to help with. GI issues, poor GI motility, poor emptying. Again, some of the basics might help a bit with electrolytes, but it can be kind of a catch-22. You need to drink more to get your stomach to empty and your gut to move. There's only so much fluid that you can take, and sometimes you really do need to have a gastroenterologist who can work with you to try to improve the GI motility. Urologist, gynecologist for some of these other symptoms here that I mentioned. This mast cell activation disorder, maybe allergy and immunology if those kind of symptoms are really debilitating. Bone density, everybody who has hypermobility to some extent has lower bone density. And so a general recommendation is to take calcium and vitamin C as you get older, especially in women, to make sure that your bone density, you keep up your bone density. If your height drops a significant amount, or you've got unexplained fractures, to get measured your bone density and get into an endocrinologist that might be able to help you. And so the support, again, go to Ehlers Danlos Society. A huge part of kind of dealing with all the consequences of these symptoms is improving your mental resiliency. And the Benson Henry Institute for Mind-Body Medicine at Mass General can give you many strategies for doing that. So just in the last couple minutes here, just wanted to kind of leave you with some guidelines if you're seeking evaluation. And again, there's no genetic testing for hypermobile EDS. So if you come and you look like you have hypermobility spectrum disorder or hypermobile EDS, and you don't have any of the other worrisome findings of a hereditary connective tissue disorder, in general, you're not going to get genetic testing. So that, if you think about that role of a geneticist, the geneticist isn't required to make this diagnosis. There are these criteria, these guidelines. Any medical provider can make this diagnosis. It may be hard to get your primary care provider to think about that, but this is a general medical condition that they could diagnose and help refer you to the proper subspecialists. Another big issue is that, as I mentioned, children are naturally a bit hypermobile, and at least according to the criteria, if you follow those, somebody before a child before puberty, is not supposed to get a diagnosis with hypermobility spectrum disorder. They would fall on that order of a with hypermobile EDS, they would fall in that order of a hypermobility spectrum disorder. Now, if you do get referred to our clinic at Mass General Hospital in the medical genetics department, we're going to review your records to see whether or not you've got some of these other concerning features other than just hypermobile EDS or hypermobility spectrum disorder. And these could be some of the things we mentioned that would be more suggestive of either a classical Ehlers Danlos syndrome or vascular EDS or something else that's more complicated. Our division has gotten overwhelmed with these consults. Quite literally, hundreds of these consults come in to us. We just don't have the bandwidth to see the patients. We have been taking them for many years, but it turns out, up to half the patients that any given provider was seeing was to rule out EDS, and the waits were building up to over a year. One of our providers who was dealing with a lot of hypermobile EDS had dropped their practice, and so we're left with over 100 patients that had been scheduled. We're trying to schedule these patients. So at the moment, we're not actually accepting referrals for just hypermobile EDS, but we're going to give you lots of information. We're going to talk to your providers about guidelines for help and subspecialists that can help you for that as a diagnosis. But if there is felt that there are features that are beyond just the ones that I mentioned with the hypermobility spectrum disorder, those ones we will evaluate and potentially see. And these are kind of the issues of aneurysms, vascular strokes, significant hernias, the prolapse, organ perforations. These are some of the things you can see with hypermobile, but they're at the extreme of the spectrum, and they overlap with some of the other connective tissue disorders, lung collapse, retinal detachments, and some of these other issues here. And so if it's just a general question that you have, that you've got hypermobile EDS and want to get genetic testing, we try to reiterate there is no genetic test. If you're trying to find a EDS specialist, unfortunately, you're not going to find that in the genetics department. We don't provide coordination of care or ongoing management. We really strongly recommend that you go to the website, EDS website, and your provider helps refer you to the subspecialists that can actually really truly help. If you do have some other features that are potentially present, chronic fatigue in POTS, we will evaluate the requests as they come in. But if there's no other higher risk features, again, we'll try to provide you and your physician and your help in terms of the potential management that you can have. And if there are some of these other features of aneurysms, for instance, and other significant features that might suggest an alternative diagnosis to hypermobile Ehlers Danlos syndrome, those are the patients that we're concentrating on in terms of seeing in our clinic. So want to again kind of emphasize that there are a lot of resources that are out there. The Ehlers Danlos Society here has, if you go to that webpage, there's a lot of information that for both patients you can also provide those to your providers. So I wanted to stop here. Have just a little bit of time for some questions that might have been generated in the chat.
Thank you so much. We are now at the end of the session. If you have any questions, feel free to enter them in the chat. We have a question regarding whether EDS affects a particular race, culture, or a specific part of the world.
I guess the answer is it can affect anybody. I would say that I'm not sure I have the statistics to back this up, but my perception, and might be just because of the referral base to Mass General Hospital, I do think that there is a higher incidence in maybe European based patients, but don't quote me on that one. It can affect anybody. And there's another question there I can see about whether it affects the lifespan. And there's a big spectrum of the manifestations, and some of these are really debilitating. We do see patients who have very minimal mobility. They're almost bedridden. They might have G-tubes or colostomies, multiple issues, problems with their nutrition, and those kind of chronic issues can affect the lifespan. And I think the challenge is trying to get them optimized in every way that we can. Another really good question is, why haven't we discovered any genes? A lot of us think that as I was kind of pointing to, you can explain a lot of the manifestations by an abnormality in collagen. But exactly how it is affected, um, we don't we don't understand. There may be changes to um, the way that the collagen is processed. There is a whole new field of genetic disorders that we're just starting to realize. When we talk about the genome, there's 23,000 protein coding genes, for instance, in the body. And those are all the ones we're looking for pretty much when we do genetic testing. But you may have heard about the Nobel Prize that went for microRNA, for instance. We started to discover in the last couple of years that there's non-coding genes, RNA coding genes that can regulate other genes. And who knows, maybe in the coming years there'll be a breakthrough in terms of that. Another question, just in terms of management, about is midodrine enough, or should you be taking salt? So in the other medications that you have, I would say, a, a lot of this is a bit individualized. I would say it depends on how well your symptoms are controlled. But I would say at the core, almost anybody you go to is going to try to push you toward taking salt and staying hydration. Another question is hypermobile EDS a useful diagnosis? A lot of us would argue no. People are referred to us just so we can check the box and stamp them. Yes, you have hypermobile EDS. And many people erroneously think that there's necessary value in that diagnosis. And they get, if we try to explain to them, and it is kind of frustrating to us if, a lot of times we'll get all this history. It's hard to get through the history because the review of systems is positive in everything that you mention, and you're trying to get through all of that. And then you try to just do this box checking, and it is kind of an artificial diagnosis. And some people walk away extremely disappointed because they came 2 points shy of hypermobile EDS, and we won't give them that diagnosis. And they go to somebody else that'll give them a diagnosis, and they feel, they feel satisfied with that. But the idea we're trying to get to the whole community is that this is really, in my mind, getting rid of that diagnosis of hypermobile EDS and just in doing a hypermobility spectrum disorder and really basing your treatment on the symptoms that you have and finding the providers that can deal with those symptoms, and just educating more providers that there is a unifying diagnosis, and amongst all of this, and it's really real. So that's probably a good uh, a good question to end with. There's not any more.
Thank you. I don't see any additional questions in the chat. Before we end today's session, do you have any final thoughts you'd like to share with the audience?
Well, I would just like to, there may be some people out there who do have, many of the manifestations, and then there's a potential lot that we see, and it's very frustrating. By and large, the medical community has done a poor job of dealing with these individuals who are most severely affected. Trying to find somebody to coordinate their care and get them in to see specialists. We kind of realize the high burden that's there. We're trying to work, within our system. It's just, we just haven't been able to get a lot of success in like building an EDS clinic, for instance, and finding a specialist. There are some out there, but really what we're trying to do at the moment is just really trying to educate everybody. And I think that would be my advice to patients, is to try to educate themselves about these diagnoses, not so much focus on whether it's hypermobile EDS, but try to have just a better understanding about what's going on with your body. And if you can think about the root causes as we've talked about today, and then just being really proactive in trying to seek physicians that can help you, and we can give you a little bit of guidance if you contact us in terms of some of those. They're kind of constantly changing.
Thank you, Dr. Sweetser. You also provided a helpful resource, the EDS Society, which I also included in the chat for folks who are interested, as well as the Blum Center website. As I had mentioned, this session is being recorded. It'll be made available on the Blum Center website, which will take probably about a couple of weeks, and it'll be available at masschannel.org/Blum-Center. Thank you, everyone.
Okay, thank you. Bye-bye.
Take care.